this space in the U.S. So congratulations to you guys for the years of work.
Bruce Ramshaw. I'm the chair of surgery at the University of Tennessee in Knoxville. And for the past over a decade or so, I've been really focused on using systems and data science applied to healthcare. And for a decade, that didn't go very far. But in the last 2 years, for 5 years, I had no paying job. I got kind of forced out of any job because nobody would do it. But University of Tennessee is embracing it, and it's really about measuring and improving any process in healthcare. And so with the multimodal pain and enhanced recovery concepts, being able to introduce that into a patient process and measure the impact in terms of value is what we're doing. And obviously it's a very patient-focused thing for the experience of a human being undergoing a surgical procedure and what they go through. And we have a very large population of patients. I'm a hernia nerd, so very large population of patients that have chronic pain after hernia repair. And using systems and data science, we've learned a lot about what are the factors that impact that negative outcome. And a lot of it, some of it's possibly mesh as a contributing factor, but mesh doesn't cause pain. Mesh may be a contributing factor, but there are many, many other factors. And we're learning a lot about the patient's cognitive state as probably the most dominant factor. And so for the past year, we've implemented mandatory cognitive therapy as part of prehabilitation, and we're seeing a pretty significant impact on outcomes by doing that. So that's my thing. I teach. University of Tennessee has been right place, right time. I'm a professor in the business school. I teach this in the MBA and executive MBA programs. We're building a biomedical program with College of Engineering around these concepts, and so I've enjoyed learning from this group over the past few years and applying that knowledge in a systems and data science way to our patient care.
I'm Stephen Calley. I'm a senior medical director currently with Ashfield Healthcare Communications. Shannon Miller and myself have been working with Pacira for the last 3.5 years. So really what we try to do is, we enjoy all the insights that we get from the discussions that we have during these meetings, but it's also the dinners and the sort of sidebars and the things that give us a little bit more perspective and allow us to sort of connect the dots a little bit and sort of bring that value back to Pacira whenever possible, and sort of harmonize things across projects.
Yeah, thank you. So the way I was, I know we have an agenda here, but the way I was hoping we could do this is talk about pain management for laparoscopic procedure as a whole, because even bariatric surgical procedures nowadays are mainly done laparoscopically. I'm going to present the LabChole data, which have put together a systematic review of LabChole, which I put together. It's not published as yet, but it's part of the prospect kind of discussions. And then what I'm hoping to do is go into details of each of those procedures. Example, local anesthetic technique and what are the different nuances of local anesthesia technique, or NSAIDs and COX-2s and ketamine and all the other stuff. So we'll go into details of that. And finally, I have a almost equal amount of a section on pain after discharge, an area which is not being really addressed, and that's where the opioid crisis, I'll discuss that, because I think that's an area which really needs to be emphasized, and that's where we're missing. So these are just introductory slides. First, LabChole, and correct me if this information is wrong, was performed in the mid-'80s. Now in the U.S., almost about 1.2 million LabCholes are done, while in the UK there are about 70,000. And we all know about the reasons why we are going to minimally invasive surgical procedures, less surgical stress. Though it's assumed that laparoscopic procedures would have less pain than open, majority of the studies have shown that that's not necessarily true. In fact, the pain after laparoscopic procedure is different. It's not the so-called somatic pain or incisional pain. It's more of visceral pain, and that has been overlooked. And visceral pain cannot be corrected by opioids, while somatic pain may be. So shoulder pain, the overall discomfort, which patients can understand as pain, and that is the area why even all the recent data, and I'll show you some of the data which we have looked at, show that patients after lap surgery have significant amount of pain. So this is that paper which we just got published this year. What we did was Eric Rosero is one of my junior faculty who's has a lot of interest in statistics. We bought data from New York, California, and Florida. And the data we got was the ambulatory surgical data, the ER data, and the hospital data. So we identified lap chole as one of our initial procedure, and then now we're going to look into other procedures. And if a patient has lap chole done, obviously we have their identifier, social security number, and then if they get admitted in the ER or in the hospital, we can easily track that using our statistical package. And that's what we basically look at. Our primary aim was to look at hospital admission, that means on the day of surgery, rather than going home, the patient would be hospitalized for whatever reason. And the second other outcome we looked at is readmission. So hospital admission and readmission rates. The data we looked at were from 2009 to 2011. There were 230,000 more lap choles done in 890 facilities. And there were 0.6 per thousand of unplanned admission. That is where the patients were not discharged home. They were sent to a hospital. And the readmission rate was about 20 per thousand. And as I'll show you in the next slide, the most common cause for the predictors for readmission were obviously surgical and infection, but next in line is pain and nausea, vomiting, which is what started off and it still remains. Yeah.
Was there a way to see ED?
Yeah.
Not readmission, but ED visit?
Yes.
Because I think there's a higher...
Easy visits, and they were not admitted and sent home. Yeah. I have that data as well. Okay. Yeah. And most of them were mainly nausea, vomiting, where they came to the ED, they got whatever the nausea, vomiting, and pain as well, and then were sent home and not admitted. Yes, I have all that data. Then surgical point of view, acute cholecystitis, intraop cholangiography, and procedure performed on a weekend were high predictors of 30-day readmission. And this was the interesting part for us, that anything which was performed on a weekend for whatever reason, they had a high... and
you're doing it.
It was an independent factor. I don't know why.
You don't know diagnosis, because it could be that's acute cholecystitis as opposed to biliary cholangitis.
No, but these were done in ASCs.
That was my other question. So these are non-hospital-based
These are all
centers.
890 ambulatory surgery centers, freestanding ambulatory surgery centers, not hospitals.
Scheduled Saturday cases.
Yes, scheduled Saturday cases.
Saturday.
Yes. In fact, I went into details of those cases and couldn't find a reason why there was a higher instance of readmission rate. The reviewers were also insisting that we provide that, but the database doesn't have that, so we don't know. So, pain point of view, still almost 12% of patients have increased readmission from pain. So pain still is a major problem. And then others, nausea, vomiting has cut down significantly over the years. When we trended this, we saw that nausea, vomiting was about 15% in 2000 and came down to 4%, 5% in 2011. So slowly, gradually, it's fading away. This is another paper from Germany. It's, again, the largest database in German database, and they also basically found the same results, that the patients undergoing laparoscopic cholecystectomy or minor surgical procedures actually had high pain and worse pain than open surgical procedures. And for the open, the majority of the patients received opioids. For the so-called minor, they got nothing. Now, we got to compare and contrast Europe versus U.S. In Europe, opioids are not given at discharge as much as we do in U.S. And therefore, my guess is that the reason why